Aortic regurgitation. 26 years male presented with shortness of breath, chest pain, high volume collapsing pulse, Corrigan pulse. Blood pressure 140 over 40 millimeter of mercury at upper limb. Popliteal BP 200 over 40 millimeter mercury. Apex beat is 6 intercostal space lateral to the left mid clavicular line, forceful but ill sustained. Diastolic thrill along left lower sternal border. First heart sound loud in apical area, second heart sound soft. There is a mid-diastolic murmur in apical area which is low-pitched, localized, rough, rumbling, grade 3 by 6 is intensity, best heard with bell of stethoscope in left lateral position in breath hold after expiration. Opening snap is present. There is also an early diastolic murmur in left lower sternal border, blowing, grade 4 by 6 in intensity, best heard in sitting position with leaning forward in breath hold after expiration with the diaphragm of stethoscope. What is your diagnosis? My diagnosis is chronic rheumatic heart disease with mitral stenosis with aortic regurgitation with NYHA class 3 with sinus rhythm. But patient had no history of rheumatic fever. Sir, it may not be present in 50% of cases as prevalence of chronic rheumatic heart disease is high and MS with AR is the most common multivalvular involvement in chronic rheumatic heart disease. So I am considering chronic rheumatic heart disease as underlying etiology. Why shortness of breath in your patient? In aortic regurgitation, there is LV volume overload and increased LV and diastolic pressure. In mitral stenosis, there is increased LA pressure and increased pulmonary venocapillary pressure, both of which may lead to pulmonary edema. Why chest pain in aortic regurgitation? Due to decreased diastolic coronary perfusion pressure, LVH with subendocardial ischemia, and concomitant coronary artery disease. Why high volume pulse? Due to increased stroke volume. Why collapsing pulse? Due to diastolic run of blood from LV to aorta. What are the other conditions that may produce collapsing pulse? Aortic regurgitation, PDA, epi-window, rupture sinus of Valsalva in RB, pregnancy, anemia, thyrotoxicosis, beriberi. What is Bispherians pulse? Double upstroke of pulse found in severe AR and mixed aortic valvular disease, aortic stenosis with aortic regurgitation. Does the blood pressure of your patient signify anything? Yes, sir. Diastolic blood pressure less than 40 indicates severe aortic regurgitation. Pulse pressure more than 70, it also indicates severe aortic regurgitation. Pulse pressure more than 50% of systolic blood pressure indicates severe aortic regurgitation. Why high systolic blood pressure? Due to increased stroke volume. Why low diastolic blood pressure? Due to diastolic run of blood from aorta to LV. Does high blood pressure at lower limb signify anything? Yes, sir. If systolic blood pressure at lower limb exceeds 40 millimeter of mercury compared to arm, this is known as Hill sign. This is the most sensitive sign of severe aortic regurgitation. Have you examined the eye? Yes, sir. There is retinal artery pulsation, that is Becker's sign, Argyll-Robertson pupil in case of syphilitic aortic regurgitation, Landolfi's sign, systolic contraction and diastolic dilatation of pupil. Upward dislocation of lens in cases of Marfan syndrome. What is Durogi's sign? To and fro systolic and diastolic bruit when femoral artery is slightly compressed with stethoscope. What is Corrigan's pulse? Visible carotid artery pulsation. Have you examined ADP pulse and why? High volume Bounding pulse indicates severe aortic regurgitation. What are the causes of pulsatile precordium? Aortic regurgitation, mitral regurgitation, PDA, VSD. Can all your precordial findings be explained with aortic regurgitation alone? Yes, sir. First heart sound can be loud due to hyperdynamic circulation in AR. MDM may be due to fluttering movement of AML when regurgitant jet of AR hits the AML during diastole. But I cannot explain the opening snap with aortic regurgitation alone. Can it be a case of aortic stenosis with AR? In case of aortic stenosis with AR, apex beat is heaving, presence of thrill most specific, Bispherians pulse. Pulse pressure and diastolic blood pressure will also add some clues. Is first heart sound always loud in air? No, sir. First heart sound may be soft due to early closure of mitral valve due to a marked increase in LV diastolic pressure in aortic regurgitation. Why murmur of air is early diastolic? Because LV pressure immediately fall below that of aorta after end of systole. Why murmur of AR is high pitched? Due to pressure difference between LV and aorta. What is cause of mitral stenosis with AR? Chronic rheumatic heart disease. Suppose this is the case of only aortic regurgitation, then what is the cause? Still, chronic rheumatic heart disease is the most possible cause. Another possibility is congenital bicuspid aortic valve. From your clinical findings, do you think that we are dealing with a case of severe aortic regurgitation? Yes, sir. Shifted and hyperdynamic apex with presence of peripheral signs are indicative of severe AR. How will you investigate? ECG, chest X-ray, PA view, echocardiography, 2D mode, color flow, and Doppler study. What will be the expected ECG findings in aortic regurgitation? Evidence of LV enlargement, strain pattern or volume overload pattern. Usually volume overload pattern, but maybe strain pattern also. Why strain pattern? Pressure overload due to high systolic blood pressure. What is the evidence of volume overload and what is the evidence of pressure overload in ECG? Deep Q and prominent R in V5 to V6 indicate volume overload. STT change, left anterior fascicular block, QRS widening due to high ventricular activation time indicates pressure overload. Expected findings in chest X-ray of aortic regurgitation. Cardiomegaly with LV type apex, LA enlargement may be evident, calcification in AV valve, eggshell ascending aorta calcification in syphilitic AR. Any prognostic value of chest X-ray? If cardiothoracic ratio is more than 64% indicates poor prognosis. What will be the expected echo findings in AR? To confirm the diagnosis, to quantify the severity, to detect the underlying etiology, to assess LV function and chamber dimension, to assess concomitant other valvular involvement, to detect any complication like infective endocarditis or aortic dissection. Parasternal long axis view 2D shows thickened RCC and NCC, prolapse of RCC and NCC, dilated aortic root, dilated LV. In M mode, fluttering of AML, premature closure of mitral valve leaflets, increased EPSS, eccentric AV closure line in congenital bicuspid aortic valve. Color flow study shows regurgitant mosaic jet from aorta to LV in diastole, jet white. Parasternal short axis view shows ellipsoid opening of aortic valve in systole in case of congenital bicuspid aortic valve. Apical four chamber view shows regurgitant mosaic Z from aorta to LV in diastole. Continuous wave Doppler shows density of spectral display above the baseline. Calculation of pressure half time. What do you mean by aortic root? Annulus plus sinus of Valsalva plus sinotubular junction. What do you mean by large annulus? Annular diameter is more than 35 millimeter. What are the echocardiographic parameters for severe aortic regurgitation? Qualitative: dense jet, pressure half time less than 200 millisecond, hollow diastolic flow reversal in descending aorta. Semi-quantitative: vena contracta more than 6 millimeter, jet width more than 65% of LVOT width. Quantitative: regurgitant volume more than or equal to 60 ml per minute, regurgitant fraction more than or equal to 50%, effective regurgitant orifice area more than or equal to 0.3 centimeter square. How will you manage a case of aortic regurgitation depends upon echocardiographic assessment, concomitant other valve involvement, aortic root dilatation, associated coronary artery disease. In my patient is symptomatic and most probably this is a case of severe aortic regurgitation, so definitive management will be aortic valve replacement. Before going to definitive management, I would like to give general and medical management. General management includes avoid vigorous exercise and weightlifting. Medical management includes vasodilators, diuretics, beta blockers, prophylaxis against rheumatic fever and infective endocarditis. Which vasodilators can use? ACE inhibitors, ARB, nifedipine, prazosin. ACE inhibitors in symptomatic patients and patients with LV dysfunction, beta blockers, patients with LV dysfunction, marked tachycardia, aortic root dilation. If patient presents with atrial fibrillation with first ventricular rate, then how to assess echocardiographic severity? Echocardiographic assessment should be done after controlling the heart rate. Indication of AV replacement: symptomatic severe aortic regurgitation, asymptomatic severe AR with LV ejection fraction less than 50%, LV IDD in diastole more than 70 millimeter, LV IDS more than 50 millimeter, or aortic root dilation. If your patient undergoes any non-cardiac surgery, does it carry additional risks? Yes, sir. Severe symptomatic AR is associated with high risk. What are the odds combination of valvular heart disease? MR with AR. What are the common combination of multivalvular heart disease? MS with AR. What are the common combination of multivalvular heart disease? MS with MR. Is infective endocarditis prophylaxis routinely recommended only when associated with congenital heart disease or history of previous infective endocarditis? Why penicillin is not effective for infective endocarditis prophylaxis? Because flora of oral mucosa responsible for infective endocarditis is a alpha hemolytic streptococcus, which is usually resistant to penicillin. Prognosis: AR due to bicuspid aortic valve has a better prognosis than AR due to chronic rheumatic heart disease. What is the prognosis of your patient? Heart failure 2-year survival 50%, syncope 3-year survival 50%, angina 5-year survival 50% if untreated. Echocardiographic measurement of aortic root, annulus in systole and all others in diastole. Why beta blockers is not a choice of drug for treating hypertension in AR. Decreased heart rate will be associated with more diastolic time, thus regurgitant volume will be more in diastole. Which valve will you prefer and why? Metallic valve due to durability. What is the drawback? Need for lifelong anticoagulation. Can you consider TAVI? I will not prefer, sir, because TAVI is recommended only for those patients associated with higher surgical risk. Again, TAVI is not recommended for regurgitant lesion and also not recommended for congenital bicuspid aortic valve. Thank you.